Welcome back. That completes our vaccination schedule and the important vaccines that can be asked in the question. Next, we talk about bacteriology. We'll start our discussion with the bacteria. I'll ask you a question. Whenever in the exam, when you find that a 43-year-old male patient presenting with recurrent fevers, the chest X-ray is normal, the urinary tract infections are normal, there is no urinary tract infections, but on urine dip examination, you find a hematuria. The patient appears to be tired. There is splenomegaly on abdominal palpation. What is the most important thing you'll have to select? It is the infective endocarditis that you will have to select, please. Very important. And remember, infective endocarditis can present as a spectrum. It will not present as a fever, murmur, patient is sick, patient has got difficulty breathing. No. Septic emboli by infective endocarditis is one of the most important complication you will have to remember for USMLE Step 2. If you are aiming for USMLE Step 2 275, I want you to understand the complications of infective endocarditis that are being asked. Patients will develop bilateral multiple septic emboli in the brain, which can cause paraplegia, tetraplegia, unilateral weakness, speech difficulties, whatnot, everything. It can cause everything. Remember, infective endocarditis, you will have to identify with the fever as one of the most important things. Patient will develop a new murmur. Intravenous drug abuses, infective signs of endocarditis will be absent. It is the right side murmur that is present. It is the tricuspid regurgitation that is present. It is the murmur that increases with inspiration. That is what you'll have to remember for USMLE Step 2. Whenever in the question, if you do not have time in a block, and when you see a patient presenting with so and so complaints, patient presenting with fever, tiredness, malaise, hematuria noted, splenomegaly noted, new murmur noted, Osler's notes, Janeway lesions, please think of endocarditis. If you do not understand what the patient is asking, there are only two diagnoses in USMLE. One is SLE, another one is infective endocarditis. However, I have told the code for identification of SLE. It is the thrombocytopenia. It is the female. If the patient has got hematuria, anemia, splenomegaly, male patient, risk factors, go for infective endocarditis. I want you to understand that the emboli, the infective endocarditis emboli can go anywhere and can present with the infarctions of any of the organs. I want you to understand this. When we talk about infective endocarditis, the most common question appearing in the exam is patient has got a prosthetic valve. What is the most common organism that you will have to identify? It is the Staphylococcus aureus. Remember, in step 2 USMLE, they will ask you the organism as well for infectious diseases, if it is related to infectious diseases. Please remember Staphylococcus aureus as the prosthetic valve, as a intravascular catheters, any devices, patient has got pacemaker, and patient is a intravenous drug abuser. Staphylococcus aureus is the most important thing you will have to remember first. Whenever the patient has visited a dental doctor, you will have to select a viridans streptococci as one of the most important thing. Whenever in the question you find that the patient has got a bronchoscopy that is done for a CT scan which shows a tumor or a mass or anything, or when the patient has got a biopsy by bronchoscopy and now developed fever, malaise, and everything, it is the streptococci that you will have to select. Oral cavity, trachea, it is the viridans streptococci that I want you to remember. If it is prosthetic valve, it is staphylococcus. All right. If it is a prosthetic valve with slime layer formation, it is if it is a prosthetic valve with coagulase negative, it is Staphylococcus epidermidis, please. If it is a catheter with slime layer formation and coagulase negative, it is Staphylococcus epidermidis. If it is an implanted device with slime layer with coagulase negative, it is Staphylococcus epidermidis, please. Patient has got a history of urinary tract infection and is currently on antibiotics, but the patient did not respond. What is the next best step? Please change the antibiotics. You've changed the antibiotics and then sent the patient home. Now the patient appears to be tired, deteriorated. Now he is in a septic shock. Patient's chest X-ray is normal. Do not understand what's going on. Please select enterococci infective endocarditis. Very classic question, easily missed by the doctors, even in the clinical practice. Recurrent urinary tract infections, patients not responding, now has got a new murmur, now has got shortness of breath, now has got palpitations. Please select enterococcal infective endocarditis. What do you have to see? It is the history of urinary tract infections that the patient has, or the patient will be having something that is obliterating the urinary tract infection, urinary tract. That is what I want you to select. Classic question. 64-year-old male patient presenting with weight loss, loss of appetite. He underwent a colonoscopy for a recently diagnosed colon cancer. Patient is currently unwell and has got splinter hemorrhages. What is the most important organism that can cause? It is Streptococcus bovis or Streptococcus gallolyticus. This is what I want you to remember. Patient is not responding to antibiotics. Patient has been diagnosed with infective endocarditis. Patient is now not responding to antibiotics. Patient symptoms have been flared up. Patient is on high dose of corticosteroids. Patient has got a history of HIV. Patient has got a prolonged catheter in place. Patient has got a PICC line catheter in place. Patient is admitted to the hematology ward with history of abdomen, with history of lymphomas. Patient is currently receiving a bone marrow transplantation. Patient is on chemotherapy. Patient has got prolonged antibiotic therapy for the infections that the patient is on. But the patient's symptoms and signs are not improving. He was recently diagnosed to have infective endocarditis. I want you to understand that the patient, that the examiner is talking about a fungal infection, especially candida, that he is talking about. Immunocompromised individuals, infective endocarditis, it is candida for USMLE step 2 until otherwise proven. I also want you to understand, whenever the patient is on prolonged antibiotic therapy and has still got symptoms which is deteriorating, it is infective endocarditis. It is the fungal infective endocarditis that I want you to understand. Here comes the famous question. IV drug abuser, tricuspid regurgitation, murmur increases with increase in increase in inspiration. It is a tricuspid regurgitant murmur. You all diagnosed it. On the echo, it shows there are vegetations. On the culture, it shows that it is a infective endocarditis. What are the other things that the examiner can ask you? It is the Staphylococcus aureus. That is the most common organism I want you to remember. Remember, whenever there is intravenous drug abusers or intravenous drug using patients, there will be few peripheral manifestations of infective endocarditis because it is not affecting the arteries, it is affecting the veins. There will not be splinter hemorrhages, there will not be any Janeway lesions. Next, we talk about infective endocarditis, where the patient the examiner can talk about the physical examination findings. I want you to understand, in any case of fever, if there is a new murmur, it is infective endocarditis. In Kawasaki disease, you will not have murmur. Very important. It is the coronary artery aneurysms that you will have to treat by giving aspirin. You will not have a murmur in Kawasaki disease. It is fever with murmur with rash. It is the infective endocarditis. It is the Janeway lesions. It is the painful nodes, that is Osler's nodes. You will have to think of infective endocarditis. And undiagnosed, and if you are not understanding the question and the patient has got splenomegaly, I want you to select the infective endocarditis as one of the most important things. Next, we talk about the treatment. I want you to select vancomycin as one of the most important things whenever you find vancomycin in the question. Remember, the patient, the examiner can give you that the patient has got systemic signs and the patient has got anemia. You'll have to think of infective endocarditis. What is the next best step in this patient? Please confirm that it is infective endocarditis. Get three serial blood cultures and get an echocardiography. But make sure whenever you are doing blood cultures, please select blood cultures prior to starting antibiotic therapy. What is the next best step you do? Blood cultures, echocardiography, starting the antibiotics, send the patient home. Blood cultures. What is the next best step you do? Blood cultures plus echocardiography, start the antibiotics, start him on IV fluids, refer to surgery for splenomegaly. It is the blood cultures and echocardiography. Remember, blood cultures must be done before echocardiography. Whenever in the question the examiner mentions that the patient has got obliteration of the dental things or there is a dental procedure went on recently, I want you to think that it can be because of Streptococcus mutis, Streptococcus mitis, oralis, or sorbinus. Patient has recently undergone bronchoscopy and has undergone a biopsy. What is the most common organism? Streptococcus mutans is what I will select. If there is no option of Streptococcus mutus, mitins, and miliaris, I will go for viridans group Streptococci. The patient has got symptoms of malaise, fever. The patient has got hematuria on dipstick. The patient has got splenomegaly on examination. Patient has got infective endocarditis signs, Janeway lesions, Osler's notes. And now the patient has got a culture that you are done and has not got any organism. What is the next best step you will have to do? Please start treatment for infective endocarditis. I want you to remember this because as a group of organisms can cause culture negative infective endocarditis. Hemophilus, Aprophilus, Aggregatibacteria, Cardiobacterium, Eikenella and Kingella. The examiner will not be giving you the Hasse group of organisms completely. It is the Eikenella that the examiner will ask you. It is the Hemophilus that the examiner will ask you. Remember one of the famous question, patient is 64-year-old with a COPD, with a history of COPD, now admitted with the exacerbation of COPD and now the patient sputum culture shows Streptococcus pneumonia. Treatment for Streptococcus pneumonia has been initiated, but the patient gradually deteriorated after 3 days. Now the patient has got new murmur or the patient has got splenomegaly or the patient has got hematuria. Think of Streptococcus pneumonia endocarditis. Why am I talking about Streptococcus pneumonia endocarditis in a patient with COPD, in a patient who has got exacerbation of COPD, that is infective exacerbation of COPD, not responding to antibiotics, and the patient is now having new murmur or hematuria or splenomegaly? Because Streptococcus pneumonia usually is not the causative organism of infective endocarditis. Whenever in the question you find that this patient has got infective exacerbation of COPD, it is only the scenario where Streptococcus pneumonia can cause infective endocarditis. That's the most important thing I want you to remember. There is Duke's criteria, which is usually not asked, but remember, blood cultures are the most important investigations that you will have to do. It is the blood culture positivity that you will have to show, or it is the echocardiogram findings that you will have to show. That is why the most important next step in the management remains as blood cultures or blood cultures with echocardiography. There is no important next step in the management without blood cultures for infective endocarditis. Remember this. Whenever the patient has not got an access to blood cultures or echocardiogram in the question, I want you to understand that the patient has got a temperature, patient has got a history of hematuria, patient has got a splenomegaly on examination. These are all the minor criteria that you will need to think of endocarditis. There must be three positive minor criteria whenever you find or whenever you think of infective endocarditis. I do not want to talk about definitive criteria and possible criteria. I want you to understand how the question is framed. Obviously, the question is framed on the definitive signs of definitive criteria for infective endocarditis. It is the examiner that who needs to remember the definitive criteria for infective endocarditis because they are the one who is framing the question. I want you to understand the clinical findings, which is the fever, which is a heart murmur, which is a hematuria, Osler's nodes, Janeway lesions, splenomegaly, sometimes road spots in the retina, which is usually not asked. When they ask you about the next step after blood cultures, go for echocardiography. If the echocardiography is not there and if the patient has got temperature, I want you to understand that it is the vancomycin that you will have to start. If the patient is penicillin sensitive, I want you to understand it is the penicillin that you first need to give. Remember, when vancomycin is not there, if ceftriaxone is there, it is usually ceftriaxone once daily that we need to give. There is this famous question or famous clinical scenario usually tested in every exam mentioning that the patient has got infective endocarditis. Now, the patient usually have fever, which is not responding to antibiotics, but there is an ECG that is taken or the patient has got palpitations or the patient has got shortness of breath. Patient has also got signs of heart failure. Remember this heart failure or ECG changes showing PR interval that is prolonged. What do I want you to remember? I want you to remember that there is a paravalvular abscess that is developing in patients with infective endocarditis. Whenever there is paravalvular abscess, there will be increased PR interval on the ECG. Whenever there is increased PR interval on the ECG, the examiner wants you to act as quick as possible, refer to the surgeons, or operate the patient. This patient must be under cardiothoracic surgery because he will be undergoing a valve surgery. Not only the ECG showing a prolonged PR interval, whenever he is also got other organ involvement, whenever the patient has got a septic emboli, whenever the patient has got stroke, whenever the patient has got a recurrent emboli, I want you to understand that this patient will be a candidate for surgery for infective endocarditis. This is what I want you to remember. In the question, they will also give you that the patient has been diagnosed with infective endocarditis and now the patient is meant to be started on oral antibiotic therapy. What do you want to do? Please do not select oral antibiotic therapy. It is a life devastating infection that can kill you, that can kill the patient. So intravenous antibiotics are preferred over oral antibiotics, please. This is what I want you to remember. I want you to understand the presentation of infective endocarditis, please. Dental procedures, bronchoscopy, prosthetics, catheters, and everything. I want you to understand this is the presentation of infective endocarditis. Next, we talk about typhoid fever. Typhoid fever, my favorite diagnosis is patient basically presents with the fever, patient basically presents with abdominal pain. Whenever there is fever with abdominal pain and rash, I will go with typhoid. I am not worried about what the other diagnosis is. It is the typhoid that you will have to select, please. Next, I want you to understand typhoid fever usually presents with rash without abdominal pain. There will not be a question on typhoid because abdominal pain is the most common symptom for Patients presenting to hospital. Most of the patients with fever do not present to the hospital. It is only with the fever and abdominal pain that the patient presents to the hospital in the clinical practice. So examiner will not miss the abdominal pain as a prominent symptom. It is a salmon colored rash that we will have to identify. Whenever I say abdominal pain in the question, you will have to think of abdominal complications because of the hepatomegaly. There can be Peyer's patch involvement, there can be intestinal perforation, there can be intestinal bleeding as well. These are all the most important complications of typhoid fever. Remember, for USMLE step 2, identification of typhoid fever in the question is important because fever with abdominal pain. Abdominal pain is important. Whenever there is abdominal pain, you will have to think of the complications, please. Whenever there is intestinal perforation with the fever, the patient developed rash, think of typhoid fever, think of complication of typhoid fever, please. Next, I want to talk about scabies. Scabies is not a bacterial infection. It is a bacterial infestation. That is, the organism lives with you, within you. Whenever any state mentioning northern, eastern in the question, or whenever the patient has got history of travel, you will have to think of scabies. It is pruritic. It is mostly seen in dormitories, hostels, involving the flexural components. Scabies is the most important thing. Permethrin is first line, oral ivermectin is the next line. Permethrin topical is the first thing I want you to understand. Next, I want to talk about Lyme disease. Two most important favorite questions for the examiner. Whenever there is tertiary involvement, it is the IV ceftriaxone that we need to use. That is, whenever there is endocrine damage involving the brain or involving the heart, it is the IV ceftriaxone that we will have to use for Lyme's disease. Initial stages, if only the skin is involved or if the patient has got an early localized lesion with the fever, headache, and erythema migrans, it is the doxycycline that is the drug of choice. But examiner will test you there. Pregnant patient presenting with symptoms of Lyme, patient has got fever, patient has got rash. They will tell you very clearly that there is no involvement of neurological or cardiac function. What is the next best treatment? Please select ceftriaxone because doxycycline is not used for pregnant women. Whenever there is no ceftriaxone, you will have to select with amoxicillin. Whenever there is no ceftriaxone, you will have to select amoxicillin. Remember, if the examiner gives you doxycycline, amoxicillin, ceftriaxone, use amoxicillin, please. If the examiner does not give you amoxicillin and if the examiner gives you ceftriaxone, give ceftriaxone, please. But for Lyme's disease, it is the drug of choice. Doxycycline is the drug of choice. When we talk about Lyme's disease, I want you to understand in the question there will be fever, headache, malaise, recent trip to UK, very important. Recent trip to tropical forest. Recent trip to forest. Trek to forest. Young man couple went lesions on the skin. Early localized Lyme disease is what I want you to understand. Patient presenting, young female patient presenting with bilateral facial nerve palsy, classic of Lyme's. That's it. Patient has got a history of fever, rash, now presenting with AV block where the ECG shows that there is an AV block. I want you to simply select IV ceftriaxone as the drug of choice. Patient presenting with rash initially, which was resolved, now presenting with multiple rash, that is multiple erythema migrans. What do you have to do? Please select doxycycline as drug of the choice. Whenever the patient has got migratory arthralgia or carditis, IV ceftriaxone is the drug of choice, please. How do you diagnose Lyme's disease? Clinical diagnosis using identification of erythema migrans. That is most important for Lyme's disease. If the rash is missed or if the rash is given in the question, the next best step is serology. You'll have to do an ELISA or a Western blotting technique to identify that the patient has got a Lyme's disease. Remember, if you are doing ELISA or serology, the Lyme disease or the antigens must be going into the bloodstream. So, ELISA can be only used if it is a early disseminated infection or late Lyme disease, but it is not usually used in localized disease. Whenever the patient has got erythema migrans, fatigue, headache, myalgia, arthralgia, it is the erythema migrans that is pathognomic for Lyme's disease. Can you do an ELISA in early localized disease? No, you can't do it. Can you do an ELISA if the patient has got 2 weeks of Lyme's disease? Yes, you can do it. But the patient will be having meningitis, carditis, arthralgia, or some other systemic involvement like bilateral facial nerve palsy. Please do select ELISA or Western blot technique. If the patient has got multiple erythema migrants, yes, you can select ELISA, please. But ELISA is not usually done in the early localized disease or early symptoms. Next, I want to talk about prophylaxis for Lyme's disease. Whenever you are considering prophylaxis for Lyme's disease, I want you to understand that prophylaxis is usually given for the tick which is adult, that is a deer tick, and the tick which is attached for more than 36 hours, or prophylaxis can be given for tick that is more than 36 hours that is attached, or patient can be patient can be given prophylaxis if the tick is removed within 72 hours, or if the patient is going to an endemic area, or if the patient has not got any contraindications, that is pregnant or lactating. This is what you'll have to give. But remember, prophylaxis for Lyme's disease, one most important question I want you to understand is whenever the patient is going to a endemic disease area, that is a New England area. Very important. The bug we are talking about is Ixodes capillaris tick. I want you to understand that Borrelia burgdorferi serology is usually done whenever the patient has got carditis and neuritis. This is what I want you to remember. Prophylaxis for Lyme's disease, it is whenever the patient is going to endemic. There are other situations where you can give, but not needed. The tick must be removed within 72 hours or the tick is attached for more than 30 to 36 hours. That is what I want you to understand. Next, I want to talk about a similar disease after Lyme disease. It is ehrlichiosis. Ehrlichiosis is usually caused by Ehrlichia schiefensis or Ehrlichia ewingi. This is usually important for step 1 USMLE. But the tick that is associated is Amblyomma americanum. It is also called as Lone Star tick. Whenever in the question the patient mentions that the patient has been to a trip and the patient has got fever with drop in the blood count and also involving the liver, that is fever thrombocytopenia or decreased leukocytes or increased or deranged renal function, liver function test with increased aminotransferases. I want you to understand that this patient has got ehrlichiosis, please. Whenever there is ehrlichiosis, it is the neurological symptoms that predominate. So fever with the neurological symptoms along with the deranged renal function test, ehrlichiosis is the most common diagnosis for USMLE step 2, but it is very rarely asked. Remember the most important presentation, fever with altered mental status, with bloods involving, with liver involvement is ehrlichiosis. How do you diagnose ehrlichiosis? It is the clinical diagnosis. If you want to confirm the diagnosis, it is usually by the peripheral smear and you will have to visualize the intracytoplasmic morule in the monocytes. Remember, I want you to understand whenever there is an atypical infection and you do not know the answer in USMLE step 2, it is the tetracyclines that is the drug of choice for atypical infections. Ehrlichiosis, it is the doxycycline that is the drug of choice. Remember, ehrlichiosis, the differential diagnosis can be Lyme's disease. But in Lyme's disease, there is a rash called erythema migrans, whereas in ehrlichiosis, there is no rash. And in ehrlichiosis, the patient usually presents with fever, neurological symptoms with altered mental status, and there will be blood count that is decreased with involvement of the liver. That is what I want you to remember. Next, we talk about Rocky Mountain spotted fever. I'll send you a link and then we'll meet there. Thank you very much.